Hello, mic test.
The best way to find yourself is to lose yourself in the service of others. Mahatma Gandhi. Good afternoon, ladies and gentlemen. It is an immense pleasure to welcome all of you to the annual Dr. Nadarajah Sivarajah Memorial Lecture 2025, organized by the Faculty of Medicine, University of Jaffna. I kindly request all of you to rise at the ceremonial position and give the audience. Let's now observe a minute of silence in respect, remembrance, and prayer. Thank you, ladies and gentlemen. Please remain standing as we proceed to the lighting of the traditional oil lamp. Firstly, I would like to invite Dr. Surendra Simaran Acting Vice Chancellor and Dean, Faculty of Medicine, University of Jaffna, followed by Dr. Kingeri Puneet, Head, Department of Community and Family Medicine, Faculty of Medicine, University of Jaffna. A warm invitation to the orator for the day, Dr. Dr.Nadarajah, Emeritus Professor of Obstetrics and Gynecology, Faculty of Medicine, University of Colombo. And finally, I invite Mrs. Dr. Sivarajah on behalf of Dr. Sivarajah's panel. Thank you, ladies and gentlemen. I would like to invite Professor Surendra Kumaran, Professor H.M. Senanayakar, and Dr. Kingeri Puneet to hold the headset. Thank you, ladies and gentlemen. Now, I kindly call upon Professor Surendra Kumaran, Acting Vice Chancellor and Dean, Faculty of Medicine, University of Jaffna, to introduce the orator.
My honor to be here to take Dr.Nadarajah Sivarajah Memorial Exit 2025. Yes, Dr. Sivarajah is a well-known figure in this part of the Sri Lanka and also at national and international level. So he is distinguished public health expert and also the pioneering force in community medicine at the Faculty of Medicine with Professor Sivarajah Sundram. So he's the unique feature is always very humble and smile and well-dressed man, and also as a role model for many of the people, particularly undergraduate medical students and the public health staff. So he has contributed immensely to the public health and primary health care, particularly during the difficult time of the country. And he served more than 30 years here in the northern part, and also a lot of new innovations, and then the services are created by him. And also he worked with the WHO Northern Regional Office, and also they contributed at the national level to provide good healthcare services for all the vulnerable population during the wartime. So, and also he really worked out one of the key incident I want to highlight. What he has done during this, you all can remember that Sri Lanka achieved this eradication of polio in 2005. So this his contribution in that polio eradication phase, he was able to develop some kind of a negotiation to continue all these vaccination programs during the war period, in the war front between the Sri Lankan military and the LTTE. So that's kind of a public health diplomat. And then he always, work and try to negotiate all the parties to come for the common goal and objective. So, in recognition of this remarkable service, the family has generated this memorial lecture, and it's a great honor for this service. And the University of Jaffna and the Senate is proud to set up this and ensure this as an annual event with the undergraduate research team. So this year, we got Professor Hemant Hussain Naik. He's again another distinguished speaker and eminent professional in the field of obstetrics and gynecology. So he has done a lot of things. But he served in many positions at the national and international level. He highly respected academy in the field and the president of Asian Society of Endometriosis and Adenomyosis and the founder president of Endometriosis and Endometriosis Association of Sri Lanka. He's also the director of emergency obstetric force under the Ministry of Health and the esteemed member of steering committee of the White Ribbon Alliance, which is advocates for the respectful maternal care. His extensive academic contribution and involvement in the community activities reflect his deep commitment to improving the maternal health services. That maternal health services, in a way that Sri Lanka is a kind of a leading country, and also that most of these maternal child health indicators are comparatively better and sometimes it's comparable with developed countries because of this commitment of many public health and obstetric workers in the health system. So Sri Lanka really the first antenatal care service started in 1921, and the next year is a key year for Sri Lanka for this maternal child health because 1926 the National Institute of Health, Kalpura, was established so that the first public health institution to train the public health midwives and public health inspectors. So that country really put this very good foundation to provide the respectful care for the mother and the child because they are the key members of a family. So this losing a mother is a terrible thing. So I don't need to here to know in between this oration, but this Professor Hemant Hussain Naik in his oration, he will really that's going to highlight, and the title that he has chosen is the timely and very useful for the audience and also for us to think for the future. So his title about respectful care, the super determinants and Sri Lanka's maternal deaths. So we have to see, this how we can improve the respectful, compassionate, and empathetic healthcare for the vulnerable population, particularly these mothers and children. So we are thankful to Professor Neta accepting our invitation to be here to deliver this valuable lecture for as a memory of a remarkable public health person, Dr. Sivarajah. So it's a time for Professor Neta. Before that, we will come into the
Thank you, sir. I invite Professor Surendra Kumaran to present the medal and the memorial book to Professor Hemant Hussain Naik.
I forgot to mention that with this Professor Nadarajah, I worked maybe 15 years back in the human reproductive there's a national project for the research. So there was a chairman this one time and very helpful for us to establish some of the research services in Vietnam. Thank you so much. That's all. Professor Surendra Kumaran, the acting vice chancellor today, and the dean, Dr. Dinesh Kunje, head of the Department of Community and Family Medicine, senior professors, members of the academic staff, members of the non-academic staff, members of Dr. Sivarajah's family, dear students, medical and other spheres, and ladies and gentlemen. Let me begin by thanking the Vice Chancellor and the Dean and the Faculty of Medicine of the Japan University for giving me this opportunity to speak to you today in memory of a remarkable gentleman. I've never had the privilege of knowing Dr. Sivarajah, but from what I gathered, he comes through as a truly altruistic gentleman. He chose to remain in Jaffna through some very difficult years, and he didn't just remain in Jaffna, he brought in so many change and some telling interventions that touched so many lives in Jaffna. And for many of the people who were beneficiaries of this, it would have been life-changing. So thank you once again for giving me this honor. Dr. Sivarajah was born in Dr. Sivarajah was born in Negombo on the 12th of April in 1938. He had his early education in St. Mary's College. His father, being a public servant, had to relocate several times during his career. And along with that, Dr. Sivarajah had to move with the father as well. And then he attended Ananda College in Colombo. Unfortunately, in 1958, due to the civil riots, the racial riots of that time, he had to relocate to Jaffna with his family. He gained entry to the Jaffna Hindu College, and that is just 2 months before his high school examination. He relocated and he entered Jaffna Hindu College. And in a testimony to his strength of character and mind, he gained entry to the Colombo Medical College through those traumatic events. He graduated in 1965, and then he served from 1965 from 1965 to 1969 as a district medical officer, the DMO as we call it, in Ampara and Mawatagaon. Perhaps his interest in community medicine would have been kindled by working as a MOH, a medical officer of health, in many parts of the country, Kegol, Vaunia, Manipai, Anuradhapura, Kites, and then he worked as a fourth medical officer until 1981. 1981, he joined the University of Jaffna as a lecturer and then was elevated to be a senior lecturer. When he retired in 2003, he was retired as the head of department. As a teacher, he has been described as an exemplary teacher. He was always well prepared. He was accessible to his students. He made them think laterally, helped them with questions, inspired them to ask questions, and he was an exemplary teacher. He also showed a very important characteristic of forgiveness during this time. And he was attacked by one of his students, and it is said that he forgave him and treated him like anybody else. What a remarkable character. He married Mrs. Manoranjana Devi, and his two daughters were both chemistry graduates. They obtained their PhD, and remarkably, they both now work for the University of Jaffna. I think Dr. Sivarajah must have been a great leader. He was the president of the Jaffna Medical Association, Association for the Rehabilitation of the Disabled, which I think in the context of his work would have been quite a useful and essential service for Jaffna. He studied nutritional status during the conflict with the help of the WHO, and he took this story to the world and to the rest of the country. He was president of a hospice, and this is for the terminal cancer patients, and he was the president of that. He founded the Association for Health and Education, association dedicated to health education, and I believe it's in existence. We heard about this before. When others had failed before him, he managed to negotiate for the immunization program in the North to go on, despite all the troubles that were there. And then it helped with, particularly with the polio vaccination. He helped develop a night ambulance service in Jaffna, and I can only imagine what difference that would have. So all these require great strength of character and vision. We have to congratulate him on. Not only that, when an armed group was trying to organize a boycott of the A-level examination, Dr. Sivarajah intervened. And to quote him, his own words, as Tamils, we have placed a lot of faith on education. If we interrupt education, everything will collapse. And that was the turning point, I think he said. And if we allowed that, there wouldn't be a university, there wouldn't be anything. So he was able to negotiate even with armed groups. So, ladies and gentlemen, I believe, with the little I know of Dr. Sivarajah, the topic that I have chosen for you today would certainly have warmed the heart of Dr. Sivarajah. Being a cognate person, maternal mortality would have been something of great interest to him. The philosopher in him would have really liked to hear about the superdeterminants. And the kind and empathic man he was, I think would have loved to hear about respect for him. So, in his memory, I hope I will do justice with my talk. So, to begin this talk, I'm going to take you to Norway, ladies and gentlemen. So, this is Ingrid, and let's say she had a baby, and God forbid, she had a hemorrhage. What would they do? So they would give her oxytocin, use misoprostol, use ergometrine, tranexamic acid, of course, the usual uterine massage would have been done. Let's then come back to Sri Lanka. This is Bhagya. I'm told that's the most popular name that is being registered these days. So I chose that name for her. So if she did the same thing, then what would we do? We'd definitely give her oxytocin, won't we? Yeah, the bolus and the drip. Then we'd use misoprostol. We'd give ergometrine, tranexamic acid. We'd do the uterine massage. Okay, so here's my question to you. Why is it Bhagya's, actually, I'm glad to inform you that having hovered around 30, 32, our maternal mortality rate has really made a big jump downwards this time. And I understand for 2024, we are anticipating it to be even lower. So we're doing something right. So basically, for Bhagya, it's 25. We are doing the same thing as Ingrid. And for Ingrid, the risk of death, the maternal mortality rate is twice the difference. Or if it is mother who is working in an estate, the maternal mortality rate is close to 60. Why is the difference? So that for you, ladies and gentlemen, is my lecture for you in 2 slides. So in this oration, we are going to talk about some modern concepts regarding maternal mortality, what is respectful maternal care, trends in maternal mortality, description of we're looking at the maternal care system to see how we can improve, really. I'm going to present to you a summary of uh, um, qualitative review of maternal deaths that I had done for the WHO, and then we will look at how we can improve. So you would agree, the maternal death is the ultimate tragedy for a family, the healthcare system, everybody. But then, what about the preventable maternal mortality? Let's think about it. What do you think about? For me, I would say that is a disaster of apocalyptic proportions. I was born in this house, home birth. That time, my mother had a hemorrhage. I was born at 2 o'clock in the morning. That's another story. My brother here remembers the pandemonium in our house on that day, but my mother survived it. But why I'm showing you this is that I am telling you, I'm absolutely certain I would not be standing here talking to you today had my mother succumbed to that hemorrhage that day. Maternal death affects 3 generations. So the opportunities for my brother, they have been very different as my mother. Like that. You can't replace a mother, and it makes all the difference. The quality of the healthcare system, the maternal mortality is a construct of a lot of complexity. Really. It's the quality of the healthcare system, socioeconomic status, and the status of women, which I heard from my friend Dr. Bhavani yesterday, that even in the time of Brahman, women had better rights in Sri Lanka than a lot of neighboring countries. So we have a tradition on that. So we need to be looking at our quality of healthcare. Socioeconomic status goes with that. So quality of healthcare is very important. Look at some new concepts on maternal mortality. One is what is called obstetric translation. So this is something that was published in the BJ British Journal of O&G in 2014. So let me take you through this. So really, if you look at these patterns, all these countries follow a similar pattern. So the rate of drop of the maternal mortality essentially depends on where a country is at the time they start looking at maternal mortality in its serious. So they basically follow a similar pattern, and that's what is referred to as obstetric transit. Sri Lanka is at the moment in stage 4, where the maternal mortality is below 4. It's typified by over medicalization of maternal care, and also the indirect causes of maternal death coming into prominence, and also the need to address quality. The second thing that I am talking about is the superdeterminants. That's something that is fairly new. There is a Lancet series on maternal health, and you can read about it there. In fact, I learned from that. And this says that the superdeterminants, the economic system, the political system, the culture, all these things interact to affect maternal health. On top of these, we have the structural biases, like the socioeconomic status of the mother, gender issues of the mother, and ethnicity, and all these will impact maternal health at different levels. So there are individual factors, exposures, social determinants, but then let's take the status of the planet. The pollution could affect maternal health. If you take the political system, in any political system breakdown, it's really the women who bear the brunt of the problem. So these are 2 new concepts. So really, when you think about the superdeterminants, you can say that maternal health is not determined solely by biomedical factors. There are many social, political, and economic factors. However, It is the health system that is the final kind of barrier against all these negative effects that come from other influences. So we talked about the quality of care, but quality of care includes a lot of things like the human resources who are well trained, infrastructure. We need the drugs. We saw those differences during the economic crisis. We need policies in the healthcare. And when they are all good, it will produce good outcomes and a positive gain experience at an acceptable. So when these things don't work very well, particularly say competency challenges, that leads to poor quality of care. And then this is what leads to too little, too late, disrespect and abuse. So we need to address a lot of all-round things to address the quality of care. Let's take a brief look at the Sri Lankan healthcare system. Essentially, it's been described as a miracle to take the healthcare cost per capita. Many countries, Western countries, to take the US, their maternal mortality rate is somewhere in the 20s, and we are in the 20s ourselves now. And they look at the difference in healthcare costs. We are like about $112, but they are about $3,000 per capita. So we are being described quite rightly so as a miracle. We've earned praise from the best in the world, the highest in the world, that we are the best. However, this was not always the case. If you go back to the 1920s, our life expectancy was only 31 at birth, and then many cities in India were doing much better than us. However, there was one change, that is Dr. S.F. Jellappa from the Department of Health of Sri Lanka and the Rockefeller Foundation nominee, Dr. W.C. Jacobs. They wrote the Health Unit Program. Essentially, they advocated investment in the field service. Here is a picture of the first health unit, which was started in 1922. And seeing the success of this health unit, they expanded to other parts of the world, the country. So here is the famous graph that's been shown often. You invest in the public health midwife, the maternal mortality rate will go down. It's more or less a mirror image of how the number of midwives impacted on. And I think the field service is continuing its sterling service. So our maternal care delivery happens via two arms, the field service and the institutional arm. That's basically the hospitals and that's people like us work. Let's look at the field service first. I believe that the field service is doing a wonderful job. If you look at the extreme right end of the slide here, you can see the number of women who are booked in the system before 12 weeks of pregnancy is completed is an astonishing almost 94%. And this is the figure I believe will be even a developed country will be proud of. If you look at the postnatal service, you can see, let's look at the first row, 2021, because of the COVID, the figure has come down. Let's leave that. And the number of mothers receiving at least one visit by the public health midwife in the first 10 days, within the first 10 days, is 80.9. And also average home visits is 1.7, almost 2. So this is a wonderful service. We need to see why is it happening? How are they achieving? We are not thinking about it. So the field service has key performance indicators. A lot of people, the field midwives, will come and ask, have you taken the tetanus injection? One of the main reasons for that is that the tetanus injection, the percentage taking the tetanus injection is taken as performance indicator. There are so many things like that. The number of weeks at the time of booking, number of home visits, these are all key performance indicators. So these are monitored. Not only that, they are monitored. There is a very good health information system. They are monitoring it through that, and then they have consistency in execution. These are all what, whenever they are starting an intervention, it's an evidence-based intervention. Very often, not they are sort of contextualized interventions very often. Whereas, unfortunately, the institutional arm has no performance indicator. Okay, and there are variable policies. Like say, if you go to Visoita, where I used to work, 5 units. 5 units will have, 4 units will have 4 different policies. Say a woman is going past the date, 4 units will manage differently. Can all 4 be correct? So this is the problem. And then also, institution-wide, we have other problems as well. If you go to some of the peripheries, there is no comprehensive service beyond 4 p.m. So the care providers very often need to cut corners, induce the labor, start oxytocin infusions to expedite labor. These are not good practice. So let's look at some of the things. This is what I was saying. We have one of the highest rates of induction of labor in the world. Not only that, more worryingly, we have a cesarean section rate which is ever increasing. If you take the global league of cesarean section, I think with this, we might be getting into the top 10. What is happening? I think it's bad obstetrics, and I believe there is an element of lack of supervision as well. So we need to look at this in a dispassionate way. Here is the regional director-wise cesarean deliveries. See, when you draw a line at 50%, some RDHS divisions are running at over 50%. So we need to look at the quality of care issue. So let's look at the recent trends. I told you that from about 2008 here, we were hovering around 32, 30, somewhere there. Recently, we have started coming down. I hope this trend continues because the SDG goal is 16. Earlier, it's 20. It was 20, but it's now been brought down to 16, and I'm very happy to hear that figure. And I believe if we keep reducing it, the maternal mortality, we can reach that. Okay, so this is from the SDG goals. Now I'm going to share with you some features, some findings from a qualitative review of maternal mortality in Sri Lanka between 2014 and 2018. So basically, I reviewed all the records that were available in Family Health Bureau, which included multiple sources. But I want to acknowledge our colleague, Dr. Nadarajah, who was passionate in his way he dealt with maternal death reviews, not the popular man among obstetricians, but certainly he did the job that he was entrusted. So here are my findings. I reviewed 286 maternal deaths in all, and the predominant one was the heart disease. We will look at that in detail. So I looked at the demographic data. So here is the columns that dealt with the occupation of the husband and the lady who passed away. So what's remarkable is that 81% of these people belong to a lower socioeconomic class. So we talked about the superdeterminant, so socioeconomic class really matters with the poverty. Let's look at obstetric hemorrhage. And we must remember that most of the hemorrhages are triggered at the time of the delivery. So we must invest in how we look after labor and delivery. I do not know whether we are doing adequate. However, here's another problem. A lot of these women who died of hemorrhage, they were not booked with the system. You can see the people on the single, separated, divorces, cohabiting people. They were socially stigmatized pregnancy. However, there were the majority of the women, over 50%, were married. Okay, they are not in the system. And then they all many of them tried to do a self-delivery. They were grand multifarious women. So we need to look at this carefully. Antepartum rupture of the scar. There were 13 women who had died of an antepartum rupture of the scar. I'll give you more details about it. One is the rupture of placenta accreta, then a dreaded complication of pregnancy, mainly as an aftermath of a cesarean section. Only one woman died due to a non-scar related cause. So during delivery, when you look at it, the self-delivery, there was 9. Unfortunately, 6 women died during surgery for placenta accreta, damage to blood vessels at cesarean section. 9 people died. Cervical or vaginal tear and intrapartum rupture of the uterus. Basically, hemorrhage is considered a cause of death that should not exist because it is prevented. Some details about the women who died due to placenta accreta spectrum. What I really wanted to say was, unfortunately, a lot of these, out of 5 out of 6, the diagnosis could have been made, and these women could have been good staff in better equipped hospital skills and infrastructure-wise. So I want to highlight to you that cesarean sections contribute to maternal death. Although we labor under the illusion that cesarean section is safer to deliver baby. It's far from. So this is how these women ruptured the uterus, 17 weeks to 36 weeks, fairly remote from term. So when these women go to hospital, they are treated as gastrointestinal reflux disease, gastroesophageal reflux disease, etc. And for all kinds of other things, so there is delay in the diet. So placenta accreta is almost invariably a result of a cesarean section, and bleeding being triggered at the cesarean section. We know that cesarean section have a higher chance of hemorrhage. And then when you take that, out of the 67 women who were reviewed due to deaths due to hemorrhage, they constituted almost 40%. Something for us to take note. When you review, I just wanted to show some of the things that we saw in these reviews. I like this scenario. There's a 41-year-old widow who was transferred to a teaching hospital. I can tell you it was in Batiklo. She had delivered 9 days before, and then she was basically gasping for breath at the time of arrival. The VOG and the consultant anesthetist rushed to the admissions unit itself, and they started the resuscitation themselves in the admissions unit itself. She went into a cardiac arrest, but then she was resuscitated, blood was transfused, etc. So the 2 top people in that hospital dealing with this woman. But she was taken to the theater immediately, but it was too late for her. So take in contrast, this is a 36-year-old woman who had previously had 3 cesarean sections, and brought to a hospital early in the morning, having had pain for 1 day. So she also didn't think it was anything to do with the pregnancy. And then the admissions officer does what he does usually, admitted her to the casualty ward. When she arrives in the casualty ward, the nursing officer says, "No, I can't take you here because you have gone to clinics in some other place. This is the casualty ward. You have to go to another ward." And she's returned to the admissions. When she was back in the admissions, she was in cardiac arrest, and they couldn't resuscitate. So where's the counterfeit? Okay. So the postmortem, there was a rupture. Here's a third scenario. So here's a woman who, look at this story. 2 2 past normal deliveries, 1 past cesarean, had an elective cesarean section. That would have been possible, but possibly they made the correct decision. It's done by an SHO, and she was received in the ward just half an hour of finishing the cesarean section. Very quickly how at transfer. Informed regard, the HO was informed regarding the bleeding. Medical management was done, and 5:30 p.m. bleeding was continuing. You can see the heart rate is rising, blood pressure is dropping, and she was asked to, the HO only was asked to give a blood transfer. Half an hour later, bleeding is continuing, and then the SHO comes and reviews, and the heart rate is rising significantly. The blood pressure is maintained. They are asked now to give another unit of, so at least 1.5 minutes would have been lost for this heart rate to be like this. So bleeding is continuing. He was asked to transfer the patient to the theater. The mother collapsed on arrival at it. Too little, too late. That's why this mother died. What a catastrophe. Preventable death. And this is what I was saying. Preventable death is the ultimate apocalyptic disaster. So I'd like to recommend this fairly new intervention, and I believe obstetricians are using this at the moment for what is called the shock index, the heart rate divided by systolic blood pressure. So normally, most of us, let's say, will have a systolic blood pressure of 120 or 130, and then the heart rate would be, say, 80, 85 or what. So when you divide that, you get a value below 0.9. But if it rises, the heart rate goes up above the systolic blood pressure, like in the last example that I was giving. So 1.2, if it's above 1.2, there is impending adverse events. 1.7, you are in real big trouble. You need to intervene. So the shock index is what we should do. So we had some near miss reports as well. We had 58 cases due to hemorrhage, and then we had 31 that we could really review from the point of view of a near miss. And out of these 31 who had a hysterectomy, only 5 had a balloon tamponade. Balloon tamponade is known to be a very efficient intervention, which will work for 70% of the cases. And I think we need to really make sure that all personnel who deal with obstetric patients need to know how to do a balloon tamponade. It's a very simple thing. If you look at the intrapartum uterine ruptures, a lot of them had a oxytocin infusion, oxytocin infusion without an indication. A lot of them would have done very well had we left them alone. Most of these women were multi-gravid women, and probably really need not have gone there at all. So, using of oxytocin seems to be done very inappropriately. Often in Sri Lanka, we need to review that, and very often at the time of doing an amniotomy. So, if you give a lag period, we can decide we can see how the uterus is behaving, and then it acts accordingly. Amniotic fluid embolism also is triggered by inappropriate use of oxytocin. So if you take those women, 62.5% had oxytocin. So here is the 9 were already having contraction when the oxytocin was now. So this is the CTG of one of the women who died half an hour before the death. If you look at the lower part of the graph, that's what shows contractions. She's having about 10 contractions every 10 minutes, contractions every 1 minute. Too much contraction. That really is what is happening. If you look at the hypertensive disorders, and the HELP syndrome was the most common, and the problem with hypertensive disorders very often was dosing errors was very common. Here's a case scenario. 29-year-old G2 E0 admitted at 34 weeks. Blood pressure not so high, so she was transferred to a teaching hospital from where she was discharged and asked for follow-up in 2 weeks. Probably not the correct age. And she was admitted to a district hospital now, saying upper abdominal pain, which is an indication that the pressure is going up. And then she developed a seizure. When she reached the teaching hospital, she was transferred from there. Blood pressure was sky high, and she was unconscious. The admitting officer found her to be fully dilated and then gave a bolus dose of magnesium sulfate, very correct thing to do. But unfortunately, the dose of levetolol was 100 milligrams, which is very high compared to what we do normally. We start off with 20 and escalated, but here she was given, probably she decided she collapsed because of that. A stillborn infant was delivered by faucets in the ICU. Perhaps in that situation, correct thing to do, mother collapsed immediately afterwards, and 3 units of uncross-matched O-negative blood was given. But again, probably the collapse was due to the drug. To give 3 units of blood, probably kind of sealed the fate of the woman by overloading the pulmonary edema was shown on the post-mortem examination. So when a woman who is having hypertensive disease in pregnancy comes into a ward, she should be assessed both clinically as well as biochemically. And in all these women who had died, there was a universal failure to perform a comprehensive examination. Deaths due to intracranial hemorrhage is worth mentioning because there is a threshold for urgent interventions, that is 160 millimeters mercury systolic. All these people were reaching that, and perhaps emergency medicine may have changed the page. Let's look at heart disease. That's the most common type of death that happened during these 5 years. The most common cause of death was rheumatic heart disease. And at the moment, our mother's card doesn't have a tick box for, there's a lot of tick boxes, but if we added a tick box for rheumatic fever, we could assess these women separately. Here's an important thing. The cardiac lesions were diagnosed in 7 of these women only at post-mortem examination. These are women whose lesions were so severe, we would have expected some kind of clinical change. So if you take off the women who would have died due to other reasons like peripartum cardiomyopathy, and then who were those with an obvious diagnosis, if you take those people off, it goes up to 28%. 3 additional women delivered without the cardiac lesion being diagnosed. So if you add all that, 40% of these women who died, the lesion was not diagnosed. So these are the lesions you can see: severe mitral stenosis, global pneumonia, mitral stenosis features prominently in these. And then these are the things that I used. At the time of booking, there was no record of a proper cardiac examination. Here's an example from one of the women who died. At the moment, the mother's card has 3 tick boxes to diagnose, to examine the heart in every trimester. This says it was examined. I don't know what it means, but it's been examined, but the woman hadn't seen. But I think it might be better. It says that if women had a comprehensive, systematic, simple examination of the heart, at the time of booking, it would have been much better. However, we must remember mitral stenosis is always difficult to diagnose. If you have severe mitral stenosis, you can have the blood flow is not doing very well. The murmur may not be there, but, and then also it might be limited to a very small area, but then of course the other signs like the size tolerance, all those things would show us. The signs is from the Hutchinson's method, so it describes many parts to diagnose the heart disease. I propose a method which includes assessment of exercise tolerance, and then you can, while doing the abdominal examination, you can turn the patient to the left, listen to the apex, and also get the patient to sit up on the bed while she is coming up and listen to the other area with the patient leaning forward. Peripartum cardiomyopathy is common, often underdiagnosed, diagnosed as asthma sometimes. So we got to be careful when you're diagnosing asthma in women who have never been asthmatic before when they are pregnant. So unfortunately, 11 of these women had the symptoms coming in the puerperium. Almost all of them, the 10 of them had that midwife visits, but unfortunately, our midwives are not told to count the pulse, the heart rate, and the respiratory rate when they go to visit the mother postpartum. We had these women would have been referred to hospital earlier. We're very brief about the deaths due to abortion. Fortunately, numbers are going down, but the estate sector, which constitutes only 4% of the population, contributes disproportionately. Number two is that the vast majority of the women who died of abortion-related causes were within marriage. They were married women. Just a brief look at respectful maternal care. It combines the emotional aspects of labor with safe motherhood. Earlier, we used to talk about safe motherhood about 20 years ago. So if the mother and the baby went home all right, then that's safe motherhood. Here we are now adding the emotional aspects. From every aspect of it, I believe that it will enhance quality of care, and quality of care is what we need to be addressing today in our country. It's been defined in so many different ways, but there are 12 components that have been identified. So it's further from just being free from harm and mistreatment. There is privacy and confidentiality. We're not talking about dignity of our women, etc. And we'll talk some brief aspects of it. Sometimes disrespect and abusive care is unintentional very often, both at the level of the individual and during sometimes the abuse could be institutional. I'll show you a surprising example. Let's say one of our mothers is having a baby. May not be Jaffna, but certainly this is what is happening in Karam. So let's say the woman is admitted at 6:30 in the morning to the labor room, and the husband comes with her breakfast at 7 o'clock. The husband is not allowed to see the woman. Husband goes away with the breakfast. He's not allowed to eat, etc. 12 noon also the family comes to see the Mrs. Vessel, and the family can't see, and Mrs. Vessel can't see the family. There's no contact with the family. At 6:30, the decision for emergency cesarean section is made. From what I told you about cesarean sections in Sri Lanka before, the rising rate, I don't know whether it was a necessary cesarean section as well. And then 5 o'clock family comes, but she's in the theater. And 5:40, healthy baby is delivered. The family is waiting outside the theater, and the security comes at 6 o'clock, telling the visitors, This is what happens in Colombo. I don't know about that, right? So mother had taken and baby are taken back to the ward at 6:40, 6:45. So if everything was going according to the rule book, that mother would not have seen the husband or the family that whole day. The family may not have seen the baby as well, but you know, these are things we need to think about. It's really but it's individual, it's institutional. So I see a lot of obstetricians here. I think young obstetricians as well. So this is what we tell a lot of people, right? So normally when a mother is examined, no explanation is given very often. That's what happens in Colombo. Okay, no explanation is given. The mother is examined. The doctor writes the findings. Usually not told to the very often it's not told to the mother, and throws the notes and goes away. But then can we make it different? It's very simple. So if you say, if I'm going to see a mother, I will say, I'm Dr. Senanayaka, I'm going to be looking after you. Don't worry, you're going to be fine. Okay? If he said that, it will be very different. So if I tell her, look, I want to see how your labor is going. I want to examine you from below. The woman will be very happy to, and she won't be scared. I usually tell them, and in fact, this morning I conducted a workshop on vacuum delivery for some young doctors, and one of the things I told them to tell is when you're examining the patient, tell it shouldn't hurt. If it hurts, I will stop. The woman won't feel any pain then, really. So if you, after examining, we can tell the woman, look, your baby is coming down very well. The cervix is dilating very well. You're going to deliver it without any problem. These are things we remember. The birth is so primal that what happens in labor is remembered by them forever. I'm sure the ladies here will watch for that. There are a lot of things. One of my young colleagues is doing a PhD based on respiratory care at the moment, and then some of the things that I'm telling you coming from his research. So we found that mothers find it hurtful when the care provider, with all good intentions, right? With all good, now you push the baby stuff. Now you push the baby out, and the woman is trying her best. She finds it hurt. It's not good for you to shout. They find it hurtful. So these are little things we need to take this. So this is the usual. Why did you come to the hospital? Say a woman is having a death in utero, and very often the first thing that is, so why did you come to the hospital? What is the purpose of asking that question, for goodness sake? Okay. So there are a lot of young grand multiparent, teenage pregnant women, when they are in labor, some of the things that are told, it's virtually obscene. Okay. So these things are happening. This picture is from a hospital in the Philippines. But if you look at the woman and the number of people around, we're not looking at the dignity of women. I mean, we are not looking at dignity at all. So here, this is very familiar to us. In Western countries, husbands are there. You can see this often when you go to a labor room. But what is this country? This is our country. This is a labor room in a private hospital. Okay? So where is the equality? There is a big gulf between what we are doing in the state sector and what the women are getting in the private hospital. In a private hospital, if there's a cesarean in a Colombo, the husband is there. Okay? So this is the unfortunate thing, and I'll be very blunt, just like Dr. Sivarajah would have been. I mean, the same obstetrician who doesn't allow her companion to come into the labor room would do a cesarean section in the afternoon with the husband. And I think that's not right. Right. What about having a birth companion? I have been a passionate advocate for this for a long time. And I'm very glad to see it gaining traction in Sri Lanka. Because, it's not like having a companion is not somebody who is just looking after your loneliness or giving you support or whatever. There are many other benefits, and there are two large reviews. I mean, thousands of women's data has been looked at in these studies. There's a higher chance of a vaginal birth. Mother is going to think more positively about or less negatively about the birth. Labor is less painful. So postpartum energy is going to be less. No. Very importantly, you're going to have a shorter labor because the mother is secreting less adrenaline. And then we are seeing this all the time. And we've done these studies in Colombo as well. And we are seeing results. Okay. Less requirement of a cesarean. Okay. And so in the context of our cesarean section epidemic, these are important. So there are a lot of other benefits. Here's a video of one mother. This woman is 8 centimeters when I took this video with their permission. She's not swimming her head off. Okay. And I want you to note the amount of distance we have between the beds. Just public curtains. Okay. One of our colleagues at our hospitals in Colombo has now started allowing the husbands in. You know, what they are telling me is that the husbands sometimes want to leave and the wife is not allowing them to leave. Okay. So it just needed some very small infrastructure adjustment, just putting up a kind of a barrier, that's all. So pardon the singular here, I'm sure a lot of people can't read it, but you know, we had a lot of letters, we have a file that big, you know, people thanking us for allowing a labor companion when we started allowing. Here's our experience. We find they help with the mother changing the position. These days we say don't allow women to labor in the supine position. Sometimes we encourage people to have clear fluids during labor, and these people help to give the mother the fluids. And because there is another person there who is erect, the labor, our staff will look after the mothers better. If there is better, we found that the low APGARs were less than these women who had these. Better and more respectful communication, better analgesia. We've had mothers telling the nurses, I mean, it's just look at this lady, she's having too much pain, can't you do something about it? You know, better analgesia. But you remember that the evidence is that they will have less pain. Maternal anxiety is less, greater accountability, right? And also more risk. So that's been our experience. It's a very positive thing. I would really urge you to consider it. The Ministry of Health has put out a circular as well. Unfortunately, it is observed in the negative also. We did a study on why this is not happening in Sri Lanka. And the commonest reason that they gave us was that there isn't adequate space between beds. But really, this is from our ward where we started, ward 15 in the Sivarajah. We have only 30 inches between the beds, and you can see the mother there stroking the back of the laboring mother. Currently, 70% of our mothers have a labor companion. And the people who don't have a labor companion are people who say, no, I don't have anybody to bring. You know? So with the curtains that we have, we can't get the man in, but certainly the female companion is working very well. So how can we improve? Are we making the best use of our most precious commodity, the consultants, right? This is a strange thing. I was surprised when I thought about it, right? If you take the consultants in our Ministry of Health, they are contracted to be on the ward from 8 to 12 noon and 2 to 4, 6 hours. Okay? Only 6 hours. But the rest of the time you should be available, right? So if you take a hospital that has 3 VOGs, okay, so these women will have contact with their consultants under the best of circumstances only for 6 hours, 18 hours, they will labor without direct contact with them. And we were talking about how important it is to invest in the management of labor. However, if we change the system and we have a roster, you have, there are infrastructural changes and policy decisions that we have to be made. We can have consultant cover for longer than that. Maybe let's say 12 hours. Direct consultant cover as against the 6 hours before. Another thing that's going to help that is abolishing separate labor work. I would say you must have a common labor. You can have evidence-based practices, not 3 different policies for 3 different labor laws. No, create a consultant. So one consultant will be covering the labor law. We can focus the human resources, particularly an epidural service, etc. An initiative cover for that. A dedicated HO, SHO, and then we can have policy-driven management policy, so that we could improve the quality there. And I think sometime we will have to get that, because the system we have, the 6 hours cover, is really outdated. And I believe it belongs to 1950, not 2020. We need quality standards, just like the midwives and the regional directors and all those people who are working in the field system, which is doing wonderfully well. We need quality. We need to look at cesarean section rates. At least, unfortunately, nobody is bothering about it, right? Not the Ministry of Health, not the obstetricians, not the College of Obstetrics. And we keep increasing the cesarean section rate, which really raises questions about the quality of care. So there are so many things that we can do, number trained in emergency obstetrics. We will talk about that, in a few minutes. There are scoring systems as well. The Bologna scoring system takes into account all. In many of the cases that were reviewed, it was found that the quality, the emergency management quality was very poor. Hemorrhages are diagnosed late, and emergency management of a collapsed patient is very poor. The drugs are not used properly, either not given or wrong dosing. So we have a emergency obstetrics course. We brought this in 2016. We have a very well organized one. We've got a team from Jaffna as well to come to Colombo to try to establish a center here. I hope that happens. So this is how we do it. We have lectures and then breakout sessions. Very good quality course. Actually came from the Liverpool School of Tropical Medicine. Government spent a lot of money to get that course down. And we have so far trained 1,100 people over 1,100. So we are making a big difference in what we are doing, because these are the pre and post test scores. Because we do a pre-test on mannequin. So a collapsed mother, asphyxiated baby, shoulder dystocia, and a breech delivery. So people have a pre-test and a post-test. These are the scores. Look at the pre-test scores. Some of them come with a knowledge of 0, particularly in a collapsed mother. If a mother collapses, God help that woman. Shoulder dystocia, God help that baby. So we have to have that. And I really urge my colleagues here to get together and establish one. And you need to give 2 days for a month. That's all. Here we went to Baticalo to start a unit there. We established a training center in the College of Obstetrics. But why I'm showing you this, that we need to get mannequins, and that costs money. But I think if you get the public involved from here, this is the paint company that's doing this for us. We can get the public interested. Public can get interested in so many other ways as well. So we had this fashion show, raise funds. So the public is interested, and these people, 18 people who played cricket for Sri Lanka, came forward, and then they were very, very enthusiastic to help us. And um, finally, so how do super determinants, respectful care, and Sri Lanka's maternal mortality rate how do they intersect? So, like we said, it's maternal mortality is a complex construct of multiple factors under the category of super determinants, and these are beyond the control of the individual or the healthcare system. So, to reduce maternal mortality in Sri Lanka, I believe that and I firmly believe we are performing below our capacity, below our potential. We can do much better than, although by regional standards we are doing well, by global standards we are doing very well, we can save more mothers. I firmly believe in that. And we need to improve, we need to address the healthcare model, foster accountability, and enhance the access to emergency obstetric care. And I believe, and I really wish that for the Japanese. With respect to care, there is no direct evidence that it will reduce maternal mortality, but it generally improves quality. That's what we found. We have shown with some evidence of that. And um, I believe at least whatever it doesn't do will make our care delivery more human and more kinder. And that's, I want to make a plea to everybody here to consider the companion as well. So finally, I want to remember my mother who survived that postpartum memory. She didn't survive. I think she survived partly because of uh, willpower, I think, and I wouldn't have been here, really. And then also, my father had the presence of mind to drive down at 2 o'clock or 3 o'clock in the morning to Kalutara and pick up a general practitioner and pick up a bottle of tincture of opium, which was the only thing that could have saved my mother at that time. No oxytocin. And so I want to remember them. I want to acknowledge my brother who is here and with his, my other brother, they coached me for the O levels when I was really running wild in 2 weeks. And if not for them, I wouldn't have passed my O level as well. So thanks very much. And thank you very much, ladies and gentlemen, for listening to me so patiently. I want to leave you with this thought. One that is too many. So thanks once again for inviting me to and giving me this honor of delivering this lecture in memory of this remarkable gentleman, Dr.Nadarajah, Sivarajah. He was tenacious in his belief, and he was a person who was courageous enough to stand against the guns and the system and innovate for the good of his people. And really, I think he touched so many lives. So it's a difficult thing to honor the memory of such a person. I hope I have done him justice. Um, I want to also leave you with the thought that we, in our positions, also carry the power that Dr. Sivarajah had to make a difference and to touch countless lives. So thank you once again. Thank you to the Vice Chancellor of the University, and thank you very much for your patience here, ladies. Thank you.
Thank you, sir, for enlightening us on how and why Bhagya's care differs from Ingrid's care and how we can improve with a truly remarkable lecture. Here's to hoping that both women will receive the same level of care and respect in the future. Thank you once again. Let me again invite Professor Surendra Kumaran to present the memento to Professor Hemantha Senana. Thank you. As we near the conclusion of this event, let me invite Dr. P.A.D. Konye, Head, Department of Community and Family Medicine, to deliver the vote of thanks.
Good evening, everyone. It's with profound gratitude and respect that I stand before you to propose vote of thanks for this deeply meaningful memorial lecture. Today we gathered to honor the memory of Dr. Nadarajah Sivarajah, a dedicated teacher and a public health person who left an indelible mark in the field of public health and on the very fabric of our medical school. First and foremost, we extend our sincere thanks to our esteemed speaker, Professor Hemantha Senanayake, Emeritus Professor Obstetrics and Gynecology Department, University of Colombo. Sir, your insightful lecture titled Respectful Care, the Superdeterminants and Sri Lanka's Maternal Deaths was both enlightening and deeply moving thing. You skillfully touched on the very recent updates related to maternal deaths in Sri Lanka and its determinants with your strong research findings. Your suggestions to reduce maternal mortality, including the birth companion and other things, will be a guide for our professionals. Your words not only honored Dr. Sivarajah's legacy, but also inspired us all to strive for excellence, pursue innovative research, and provide compassionate care. Thank you, sir. We would like to also thank our Vice Chancellor, Professor Sivarajah, and the Dean of Faculty of Medicine, Professor Surendra Kumaran, for their unwavering support and commitment to fostering a culture of remembrance and academic excellence at the University of Jackson. We are also deeply grateful to the family of Dr. Sivarajah for their presence and for sharing their memories. Your participation made this event truly special and allowed us to connect with the personal side of remarkable individuals. Our special thanks to Mrs. Dr. Senanayake, wife of our orator, and elder brother of our orator, Dr. Jayantha Senanayake. So you are traveling far away from us and joined with us in this special occasion. Thank you very much. Our heartfelt thanks to go to the academics and non-academic staff of the Department of Community and Family Medicine, University of Jaffna, for their meticulous planning and execution of this event. Your dedication ensured that everything ran smoothly and that this tribute was conducted with the dignity and respect deserved. We also thank the Deputy Registrar and the Dean's staff, University of Jaffna. This event was made possible by your support. Additionally, we thank the academic branch staff of the University of Jaffna and the Deputy Registrar. We could not have done this without your help. Finally, we extend our gratitude to everyone you for attending this memorial lecture. Your presence is a testament to the lasting impact of Dr. Nadarajah Sivarajah and the importance of honoring those who have shaped our institution and our profession. Thank you so much.
Thank you, sir. It has been a fruitful day, ladies and gentlemen, with a remarkable man honoring the memory of another remarkable man, all while prompting us to think about our approaches in maternal care. Thank you once again for taking the time to join us today. A warm invitation to the guests to partake in refreshments in the boardroom at the Dean's office. Have a wonderful evening.
Mhm.